And the slides are there. I already shared the. So thank you. Can I give a talk or are you
Yes,
listening?
yes, please. Thank you so much for joining. Please carry on. Thank you so much.
Thank you for the invitation. Sorry, I am in Sofia for another meeting, and then I will present the requested talk about parenchyma preserving liver surgery. I have nothing to disclose. This is the map of Kerala in honor of you that are hosting me in this interesting meeting. The premise of the things about the liver surgery is that the surgeon disagree at most about resectability. And resectability, as you know, is the criteria that not only the surgeon but all the specialists fill up their studies according to the flow chart that divide the patient into main categories, resectable or not resectable. Once these two categories in reality are so mixed up, and in reality there is not a real agreement among the specialized surgical community. Given that background, we may say that the dogmatic consideration about the resectability is those represented in this review paper on natural gastroenterology, in which at the end you will see that sorry, what is going on? You will see that at the end, sorry, I don't understand what is going on. This is not mine. Conversazione in corso di traduzione. Okay. Because I am in a hotel. The target is R0 for surgery, and because of that, the surgical community, especially the Western one, has released the technique of operation done in two parts once you have a condition of multiple bilobar disease. Indeed, as you see, according to this review paper released by the group of Zurich in Switzerland, summarizing the use of parenchyma sparing in exceptional condition, only in this one, or in this one, in which perhaps you have the situation where you do surgery, but you couple surgery with ablation. While once the liver is more complex and is considered resectable according to the target of amputating, the amputation is the rule. This, in the fact, limit not only the possibility to operate the patient, because the solutions are not so many, but also to offer salvage surgery in case of relapse. Then we may see that if you consider the universe in a Ptolemaic way, which is the wrong way, as we know, in the Middle Age, in the Western country, the Catholic, the Christian were thinking that there were the ring around the earth. You have is a similar condition, because we have a few possibility to offer surgery to this patient. And moreover, when you look at the results of surgery with a staged procedure and a major amputation, the problem of R1 and the risk of mortality are not solved because the R1 is quite frequent and mortality range from 3 to 12% according to the disease. The hereticals are us because I don't know why it happens this because we challenged the surgical concept of R0, considering that once you have a tumor in contact with a major vessel intrahepatically, you may have the possibility to have a clearance of the disease quite similar to the R0. If you just detach the tumor from the vessel, sparing the vessel, then is sparing the scaffold of the organ. And this has been proven in this study that we released in 2014, 2015, On surgical oncology, on 226 patients, the R0 behaved like the R1 vascular, while the R1 parenchymal offered a dismal control. The other aspect that is important whenever you have any way, despite the fact that you could detach, but in the event you couldn't detach because the vessel is completely involved, the liver offered a further alternative to the amputation, because once you have the outflow obstructed, most of the cases have the development of communicating vein in between the two parts of the liver, the one that is drained and the one which is suffering the obstruction of the vessel. And these are offering the possibility to resect anyway without major amputation. Nowadays, we have published on surgery this paper recently, in which we offer the criteria also for the preoperative finding of discover of the communicating vein, then better standardizing this procedure. In this condition, once you have tumor at the caval confluence, occupying the segment 1, infiltrating the middle hepatic vein, in contact with the right inferior hepatic vein, with the left, in contact also with the left hepatic vein, you can count on the collateral circulation that are confirmed intraoperatively, and then offering surgery to this patient, combining complex procedure and clearing all the disease. The rate of major hepatectomy in our institution is less than 1%, despite the complexity of the disease that we are facing with. And with these two rules, so the R1 vascular and the search for the communicating vein, we developed various new operations that boost the portfolio of solution for this patient. And these operations are now accepted in this classification, in which for the first time was inserted the upper transversal, and which is this one, and the liver tunnel here in. The head of technology is anyway important. More recently, we have the possibility, because the main criticism could be, if you sculpture the organ, how can you foresee preoperatively the remnant volume? With the 3D cast nowadays, we can foresee with a high accuracy which will be the amount of the liver that we are gonna doing, even though you are planning a removal of the disease, sculpturing the organ in the way that you have seen in this situation. And then you can shape the liver accordingly with your need and devise an infinite number of solutions. So we have expanded the possibility to operate a patient with the liver tumor, even in complex situation, in a really significant higher number of solutions, like this one, which is the horseshoe operation. The mid-transfer operation, according to the distribution of the lesion and the anatomy of the organ, of course, so to preserve the inflow and the outflow, and the biliary drainage is the rule, as any kind of surgery. Or facing with tumor like this, this is a cast of a real patient with the green are the tumor, and you see that the tumor are in contact with a major vessel, and there one is distributed bilaterally. So formerly unresectable, this patient was receiving a so-called roller coaster procedure, and with detachment of the vessel, some tunneling in two parts of the organ, and the lesion were completely cleared. Combining the procedure is the solution that provide the surgery also to patients that are really formally unresectable. In this case, you have to sacrifice two major vessels, but you have communicating vein and an inferior right, and then you, with the ultrasound, confirm the solution that you were foreseeing in the simulation with the cast, detachment from the inferior hepatic vein, and at the end, again, as in the previous case, we have another, if I touch, we have this kind of solution, which is a liver tunnel with the upper transversal hepatectomy. The liver is drained by the inferior right hepatic vein, the left hepatic vein. The right and the middle are being sacrificed, but the entire part of this organ is fully perfused, and we have to do a
Okay,
partial
it's not
section
visible.
of the inferior right hepatic. Sorry?
Something else has come on the screen. Can you share the slides again? Okay, thank you. Yes, now it's come back here. Thank you. Yeah, it's okay now.
Fusion imaging is the technique that is done for the disappear lesion, which is one criticism of this surgery. The cast can be merged with the ultrasound, and then the surgeon can see the image according to the cast if he has difficulty in reading the grayscale of the ultrasound. And this is particularly useful when you have tiny lesion in the liver that has disappeared after chemo, but having the pre-chemo imaging, you can insert artificially in the cast the lesion where in the position they were, and then recognize the position of the lesion during the operation, doing the ultrasonography, and then removing the area in which the lesion were, being sure that you are exactly removing that area in which previously there was the lesion. So this is a unique experience that has been now represented by 388 patients in the intention to treat prospectively the managed database from 20 years, is the so-called parenchyma sparing one-stage hepatectomy that we started in 2004. And the principle, and now the paper is going to be released on anastomosis surgery, has been standardized with the head of the cast, identify the compass point, so the deepest lesion that are in contact with the major vessels, the border of the cluster that you try to recognize, and the cluster are visualized in this way. And at the end, you can get the liver remnant and calculate the volume of the organ, and precisely carry out the operation. Like in this case, it was a real operation. It's a sliced liver hepatectomy, and this liver is perfectly, you see the slice of the organ, is perfectly in and out perfused, and this liver will regrow, and after 6 months, a radiologist who doesn't see the scar of the patient, but only the images, may believe that the right liver is still there. Incremental complexity has been the path that we have followed, becoming more familiar to these procedures. The tumor burden score of our series is more than 9. The FONC score is 3 to 5 in 64% of cases. We divided the series in 5 periods of 4 years, and you see that the increment of the tumor burden score. This is a paradigmatic situation of a recent operation. This is a real cast, and it was really operated, and this is the final results. Is a single cluster parenchyma sparing one-stage hepatectomy, and the evolution of the complexity is proven by the fact that the R1 vascular in contact with the cover confluence with the major branch of the portal branch increased in number, the lesion that we are in contact with, and also it was maintained the majority of cases were R1 vascular versus R1 R0 and R1 vascular and parenchyma, while despite the increment in complexity, we decreased the number of the real R1 parenchyma. But this is another case in which we follow the same criteria, and is a tunneling with the sliced hepatectomy combined. Technical evolution means that, according with that I have shared with you, we were going with the principle that I have mentioned, R1 vascular, communicating and the association, to foresee the extinction of the staged hepatectomy. Indeed, in our series from 2004 up to 2017, we have done 19 two-stage hepatectomy and 243 patients for receiving one-stage hepatectomy. From that date, no more patients received a two-stage hepatectomy, despite the complexity has increased. As is shown here, the number of resection area per number of resected tumor has been, the ratio has been decreased in favor of, and then it is more complex disease, but no more two-stage hepatectomy. It means that we push the technique and the results were anyway against the use of the stage procedure. The short and long-term survival of this approach are this one. We have a mortality of 0.8% among the 388 patients. The maximum number of lesions removed were 83. This is the survival according the two groups, more or less than 10 lesions. And you see 40% of the patients had more than 10 lesions, but the overall survival was equal, almost equal, while the recurrence-free, of course, was, as expected, inferior for those who were more than 10 lesions. And this is these are the survival according to the R status, R0, R1 vascular behave better than the other two categories, and in particular of the R1 parenchyma. This is the Cox regression analysis of the overall survival. The only significant factor was the R1 parenchymal for both, also for the recurrence-free survival, and of course also the number of the lesion in terms of recurrence-free survival. Per patient and per resection area, of course, R1 vascular and parenchyma and R1 was worse than the other, while R1 parenchymal was R1 vascular according to the per resection area. The most important factor in this series is also, given that this patient with multiple disease, 70–80% recur, the possibility offered by keeping the scaffold of the organ to offer reduced surgery. This is another case of sliced hepatectomy. Over 122 liver-only liver recurrence, re-resected were 93, 76%. And this is probably the reason why we have a high rate of resectability in our multidisciplinary team, where we discuss all the patients. And moreover, reduced hepatectomy means having a survival which approaches the survival of the best candidate to transplant. So it is over than 50% of 5 years, while without reduced surgery, the survival is dismal. Comparison, we have run comparison with the staged procedure, the one stage and the Alps, with the two stage was compared with the Paul Bruce, which is the institution that pioneered the procedure in terms of, and while for the Alps, we were challenged by the Italian registry of Alps. In terms of short term, the results were in favor of one stage procedure in terms of overall mortality and morbidity. As you see, our mortality is really low. The overall survival were in favor of one stage compared to the two stage, because we didn't observe any, of course, dropout, similar to the Alps procedure. The recurrence-free survival were similar to both, but essentially in this sense, we are showing that this technique, including patient in a case match analysis that theoretically would be excluded by the two stage, signify that the two stage is not really selecting the best patient, but just privating the patient of deprivating the patient of a surgical chance. Then in conclusion, I may say that this technique is well established now, is finally recognized, and luckily with the acceptance by in annals of surgery of the definite survival, we can say that with this approach we offer to the patient a variety of solutions that otherwise would have never been, and the results are proven that we are right. The positioning of this approach nowadays should be debated according to the development of the minimal access. Of course, this kind of surgery cannot be or will be, but nowadays it seems far to be treated with a minimal access approach. And on the other hand, the results of the liver transplant, given that for that kind of solution, the patients are really super selected. Thank you very much for your attention.
Thank you very much, Professor. That was an amazing talk with quite spectacular results, and it's really interesting to see the way you have developed your procedure over the years and finessed it. So I just had a couple of questions. One was that apart from, I mean, intraoperatively, do you just use standard intraop ultrasound, or do you use contrast enhancement or ICG to identify any of the tumors, or is it just standard intraop ultrasound? That was one. And the second question was, could you tell us which are the patients you don't accept for surgery? Because, you know, you're taking patients with like, I mean, so they've got 20 plus tumors, which you know, it's quite amazing to see that and getting the results that you get. So if you could just let us know these two things.
Thank you for the question. For the ultrasound, we use the contrast. The contrast, we were the group that introduced the contrast intraoperatively in 2002, so we are sponsoring this kind of solution, especially in the multiple bilobar disease, and essentially also in the case of disappear lesion. Although for the disappear lesion, in reality, the results with the contrast are a little disappointing. For the ICG, given the fact that most of the time allow you to see the superficial lesion, mostly, we rely on the cast and on the ultrasound with and without the contrast. About the unresectable is the patient that despite all our effort does not offer to us a future liver remnant at least of 35-40% of the organ. With the solution that we can offer to the patient. The solution are based on the criteria that I show. Essentially, those patients in which we couldn't recognize any cluster, so it means some part in which there are no lesion, these are unresectable, and these are those to me, and we usually address this patient to the transplant group, because for them possibly the results of the transplant are objectively very nice. The debate it will be which will be the burdening between the two techniques. But for the rest, I think, of course, most of the patients that we operate, 80%, considering that the series is starting in 2004, is under control of chemo. And the average number of cycles is 9. So they underwent to a lot of chemo. Most of them arrived to us with the judgment of unresectability in other centers. So they receive a lot of, sometimes more than one line.
Thank you.
Prof, what is the maximum number of tumors you have resected?
83.
Do you use Pringles, Prof?
Yeah.
You do Pringles. So how long do you restrict it to?
We published in Annals Surgery in 2012 the series with the patient exceeding 120 minutes. The maximum number lasting of the Pringle has been 348, 351 minutes. And the mortality is very low. I mean, it is safe. I mean, you have to be, in line with the good anesthesiologist. Then the work, the activity, the operation is a teamwork. The anesthesiologist, possibly the most important protagonist of the surgical. And when they have some trouble, they advise us, then we prolong the interval among the clamping. So at the end, and we wait unless the patient recover. But normally, these are procedures that are safe, and the velocity of the procedure is shortening according with the habit that has increased, and then nowadays, and also the fact that the trained surgeon for this procedure in our unit are more than one, so it's okay.
CUSA is your instrument for transection. You use CUSA, right?
No. This is a question. No, we don't use. We use the cheliclegia, the suction without CUSA, and I have been corrupted only by the energy device, the ligature, but up to a few years ago, it's just like it, because it was a very nice training for the younger.
Thank you. That's really amazing. Are there any questions from the floor?
Yeah, can I say hi, Guido?
Hi.
Online. Great to see you online. An amazing talk, and I think which only you can deliver, the mastery that you have in the intraoperative ultrasound and parenchyma preserving resection. And my comment and the question would be that the complex resection that you showed, and you mentioned also that typically this may not qualify as a major resection, but this is more complex than many of the, I would say a more magnitude resection, so to say. So in terms of the current classification, what do you think that should be the suggested modification to include some of your complex resections as a major resection?
I think that we should focus on the scaffold, not on the parenchyma. Of course, the amount of parenchyma is important. We are now studying, but the problem for us is to find the validation group, because we don't have enough major hepatectomy to compare, the major amputation, I mean. But we are we have now a group of cases in a validation group, and the initial risk data are, we will present this data at the European HPB, are interesting in terms of if you keep the scaffold, the regeneration is faster and more physiological. And then it's like if you are thinking about the tree. I mean, the tree suffer more if you cut big arm, big branch off, rather than removing only the leaves. And I think that this principle is valid also for the liver. And the regeneration is quite amazing. I mean, sometimes you don't see, really a radiologist may not consider that the patient was operated, when of course the radiologist that doesn't see the patient. But I mean, I think that, of course, I am thinking about major hepatectomy. I am saying that these are major hepatectomy because we remove a quantity of volume of the liver that is because, hike. Maximum is 60-65%. So we are a little bit restrictive in terms of the future liver remnant. We don't want to achieve 30, less than 30, because I think that the patient anyhow is the technique pay something in terms of surgical risk when you below too much. I know that in some countries 30% is okay, especially in the United States, but for us not. And then with this limit, at the end is liver surgery. You have to know a certain amount of criteria, that technical issue that has to be respected. The incision cannot be an incision that does not allow you to embrace the organ. Embrace the organ is important. Mobilization of the organ, and then tactile feeling, ultrasound, and dissection. That's it. It does not have anything special except the preparation, the study of the organ, and the knowledge of the anatomy.
And
We catch, when you do this surgery, the target for us is not to skip the vessel. We catch the vessel. When you are on the vessel plane, you are in the right position.
Right. So, Guido, in that regard, having dealt with up to 83 lesions, do you have some cases you take for staged hepatectomy, or first go is the most of the time?
You add?
Staged hepatectomy in stages.
We have done, as I showed, we have done 19 cases, but since 2017, no more cases with staged hepatectomy. I mean, getting more familiar with this technique has led us to avoid this procedure, and considering that the latest 8 years have, there were cases with a higher number of nodules and cluster bigger than the usual period that was before. So the complexity increased, but the stage hepatectomy disappeared. So I am not saying that, to me, this technique has only rival, which is the transplant. The alternative is the transplant.
Thank you very much, Professor. That was we're very grateful for your time and expertise. Thank you.
Thank you very much.